Hello, welcome to the first introductory lecture on breathing is the key. I'm Herb Silver, and I will be discussing some of the basics of breathing, some of the physiology, some of what's happening with your patients, how we breathe can impact their function, and how you can impact their function with breathing. So let's start off with just discussing that uh, what are the patients that you might uh, find are impacted with breathing. It includes patients with dizziness, uh, um, post-COVID, respiratory diseases, but also your chronic pain, fibromyalgia people post-concussion, neurodegenerative diseases, people that you might consider using mindfulness kinds of techniques with. Um, all these people are affected by breathing and very specifically their CO2 levels. And it's confusing if how we were trained in school and how we were introduced to oxygen and carbon dioxide. We all learned it, but we maybe didn't learn it in as functional a way as we would like. But let me assure you, all of these people with chronic conditions can be dramatically affected by how you're working with their breathing. So let's start at the periphery and talk about people with chronic musculoskeletal pain and trigger points. And you palpate a tender muscle and you find out that it's tender and you ask the question, why is it tender? And we have plenty of evidence that shows that those tissues are hypoxic. They're lacking oxygen and the muscle is actually lacking oxygen, and that's associated with the level of pain. You can see this with laser Doppler. You can see this with EMG studies. You have to do a little calculus there because the resting activity in the muscle, the degree of it is associated with the acidity in the muscle. You get all this hissing sounds on EMG showing that the muscle is acidic and not functioning well. Uh, and and from the laser Doppler studies and microdialysis, where you stick a needle and suck out some of the metabolites in a trigger point tender area, you find that it's highly acidic and hypoxic. And we know everyone walking into our clinics during COVID that we screen, we put a pulse oximeter on their finger and we find they have bunches of oxygen in their blood. And yet right next door in the muscle, capillaries are going through this area, or at least going up to it. And they're not people aren't transferring that oxygen off of their red blood cell and into the trigger point. And then when we look at the brain, we can measure activity in the brain, actually very specifically with how your brain is using oxygen. And we find people with all sorts of chronic conditions that they're hypoxic in various areas of the brain, whether it's anxiety, depression, traumatic brain injury, fibromyalgia. All these people have very, I don't want to say specific signatures, but to some degree, their lack of function in their brain is specific to the kind of problems they're having. But there again, oxygen isn't transferring off of the red blood cell and into the brain. And why would that be? So how does it become a problem? And I'm sort of mixing up a little bit here, but what we find and what we'll discuss in a minute is that the reason why we alter our breathing is due to some sort of physical or psychological trauma. Just imagine someone scares you and you have a startle reflex, you gasp, you hold your breath, you alter your breathing patterns. Well, if that's a transient event, it's a transient event. But what if you have ongoing pain? What if you have ongoing psychological distress, ongoing anxiety? Your breathing patterns become altered. And we know this, and we discuss it in mindfulness. We lack a measure. I've used heart rate variability. I've used EEG on the brain, trying to get a measure for helping people with mindfulness activities, and it's worked, but never that well. But when I started looking at breathing and particularly CO2 levels, what I found and what I learned was that the alteration comes with how well oxygen disassociates from the blood. Oxygen needs to come off of the red blood cell, go into the muscle or into the brain, and then you have an oxygenated tissue or organ, which you don't have if you have low levels of CO2. Now, how do we know this? Well, in 1904, Bohr came up with the Bohr effect, and he analyzed what the ideal acidity level in the blood needed to be in order for oxygen to most efficiently disassociate. And this is the oxygen disassociation curve we're seeing here. And as we go further to the right, these are curves with different levels of acidity and different levels of CO2. And what we find is that it's not just the acidity, but it's actually the presence of sufficient levels of CO2 that are going to tell us what the ideal concentration of CO2 needs to be in order for oxygen to disassociate, let go of the red blood cell, and move into the muscle and brain and heart and liver. And one of the problems that I noted initially is this chart is I learned the oxygen disassociation curve in Human Physiology 101 or at some point. And I answered the questions on the test and promptly forgot it because I can't measure the acidity of the blood, and I didn't know, probably at that time I couldn't, measure levels of carbon dioxide. But now what we're using to learn about this is we're using capnographs. And to simplify this a little bit, what we can see is that as the blood becomes more acidic and as the blood has higher levels of carbon dioxide, there's an ideal level here at around 40. I drew a line up here. If these tables were drawn correctly, what we would find is the ideal level of carbon dioxide concentration in the blood would be somewhere around 40, and yet we have oxygen concentration in millimeters of mercury, we have acidity of the blood, but we don't have the pressure of the CO2. And so we don't know, when we learn this, we don't know that there's a functional way of adjusting this in our clients. So where does the CO2 come from? Of course, it comes from our muscle activity. We're pouring oxygen, or carbon dioxide, into our blood, and this is where the magic occurs. We're pouring oxygen into our blood from our muscles, and it then pours. If you think about it, like going to less levels of pressure, carbon dioxide pours into our lungs, and we breathe it off, and we think that's good because we kind of learned that carbon dioxide is a toxin, and we want to breathe off carbon dioxide, and we want to take these large tidal volumes of oxygen, air, and to get more oxygen. We want to oxygen our blood, but if we breathe very slightly, even hold our breath I hold my breath for 1.5, 2 minutes, and my oxygen level many times, my oxygen saturation in my blood barely drops at all. Oxygen level is pretty constant. But what we're not aware of is that we want to elevate our levels of carbon dioxide to an ideal level. And that ideal level we can actually measure, and I'll talk about that in a second. But what we're doing when we're altering our breathing is we're trying to capture carbon dioxide and keep it here and not overly blow off carbon dioxide. This is completely the reverse of how I thought about this. And now it's painful to say that we need to elevate our levels of carbon dioxide, because for so long I thought it was a good idea to blow off carbon dioxide, and it is to a certain extent, but where most of us are way below an ideal level for that oxygen to efficiently disassociate from the blood. So how do we do that? By altering our breathing, by taking, we want to breathe into our diaphragm, but we don't want to take large tidal breaths. And how can we adjust this specifically for the patient? Well, that's what this program is about, is what the physiology is and how to adjust it. So here we go, back to sharing the screen. So of course, oxygen comes in through the lungs, bonded to the hemoglobin, and then it can be released into the tissue. Here's the big deal here, is if sufficient CO2 is present. If sufficient CO2 is present, that's what we need to keep in mind. If sufficient CO2 is present. And here what we have is the actual pressure that's ideal, is somewhere in the 40 millimeters of mercury range. And how do you get that? We will go over in just a minute. And what you have to find out is if the person's actually low. There is an ideal level of carbon dioxide. And how we measure it is we use a device called a capnograph. And this is what we're using to learn about this. And this isn't necessarily that you have to have this in your clinic, but it sure helps us learn about it, and it'll help us explain to you how all this works. But a capnograph measures CO2 exhaled, end tidal. It's called EtCO2. And you're breathing into a cannula. And as you breathe out, this device measures the amount of exhaled CO2, and you get a pretty good correlation between what's coming out of your lungs and what is actually in your blood. It goes along pretty darn well. So here, this on the left, this is what you see on your computer screen, and in the middle. And what we see here is an ideal level of CO2, or at least the base of it, at 35 millimeters of mercury. And this person is breathing below that. They're over breathing is what it's called, and they're blowing off too much carbon dioxide. And this is a function of their breath rate. The faster you breathe, the more carbon dioxide you'll blow off, and the lower this level will be. So you need to learn how to retain the CO2, and you do that with various breathing patterns. And the breathing pattern that works specifically for your patient, there's going to be a lot of individual kinds of work you have to do with their ribs, getting there to expand the base of their lungs, and breathe with their diaphragm, and sit up straight with their posture. There's a lot of specifics. But what we find when we're measuring this is as a person starts to exhale, we can measure what the CO2 levels, retained CO2 levels are in their lungs, and how much is in their blood as a result of that. And we get this measure that we see on the capnograph. So that's what we're doing with our lungs. The other part of this is we're breathing in through our nose. And we really don't appreciate, seems like, have not appreciated that breathing into our nose is required, and lots of breathing through our mouth. We're breathing off too much carbon dioxide. We're becoming hypocapnic. We're reducing the levels of carbon dioxide by breathing off too much. And what our noses are doing is they're actually slowing down our breathing cycle. If we breathe through our nose and not through our mouth, that's one thing. And consciously, we can alter the breathing even more. But breathing through our nose moisturizes the air, which moisturizes the tissues in our lungs. That's very important. It also swirls around the air through our sinus cavities and mixes with nitric oxide that's reduced from above our upper palate. Nitric oxide is removed, is collected in our sinuses and then entered into our lungs. And you say, what's the big deal with nitric oxide? Nitric oxide is a very powerful vasodilator, for one thing. So it'll open up your lungs if open up your sinuses if you're breathing through your nose. But it also sterilizes the air. It's a antibiotic, antiviral, antifungal, and there were research studies done on this where they actually inject influenza virus into people's noses, and they do breathing exercises, humming in this case, sort of like chanting. It is chanting probably, but when you hum, your upper palate vibrates, and you release enhanced levels of nitric oxide into your sinuses, and you'll actually kill the influenza virus. People injected live influenza virus. Lucky people got to do the breathing. The unlucky people just went about their day, and lo and behold, the people who did the humming and breathing through their nose didn't get sick. That's a good thing. So the nitric oxide, when you breathe it down into your lungs, it also dilates your alveoli and enhances the exchange of gases through your lungs, which is what we're ideally about, but we want to enhance that. So there is a Bohr effect that we talked about, the exchange of oxygen from going from the atmosphere, air, oxygen in your lungs going into the blood is called the Haldane effect. And these are the terms we learned. We answered these questions. I'm sure you did. You answered these questions when you took human physiology, and you promptly forgot it and didn't know how to apply it. What we're going to do is we're going to learn techniques. We're going to be discussing techniques, and we're going to be discussing the basic definitions and science, chemistry, and actual techniques to enhance how we mix air in what I call the magic area. It's where the magic happens in the alveoli. And the reason it's magic is because if we can increase our retained carbon dioxide, we can elevate the carbon dioxide in our blood, enhance the release of carbon dioxide going from the red blood cell into the muscle and into the brain, and help our patients with all sorts of chronic issues, as well as this is what a lot of sports performance people are doing. So this covers the whole gamut of enhanced performance, and this is the introductory lecture to the physical program, Breathing is the Key. Look forward to talking with you again in the future, and getting feedback and taking you on this journey together. Thank you very much.